Good afternoon. So we will start off with our first video lecture on neurologic functions, specifically on assessment. For your assessment, the first thing we have to take note would be the health history of our patients. Under health history, we have here we have to take note of the chief complaint and the history of present illness of our patients. Under this, we have to take note that we have to document the event that prompted the patient to seek medical attention and describe any injuries. An example of which is if the patient is suffering from pain. So if the patient has pain, we have to take note of the onset or when did it start to happen. The severity of the pain, we can assess this by using our pain rating scale, noting the location or any presence of radiation of the pain, and of course we will have to ask the patient for how long is the pain, or for how long does the pain usually last. So that would cover your duration. Under health history also would be your past medical history. Under your past medical history, you have to take note of the past neurologic disorders and pertinent signs and symptoms, which are vital pieces of information so that we will have an idea of the current situation of our patient. So what are examples we need to take note of? Any history of head injuries, seizures, diabetes mellitus, hypertension, heart disease, and cancer. We also have to record dates and types of immunizations and the current medications our patients are taking in. What else? We also have to include allergies. In this case, for example, is any allergy or any existing allergy for your iodine-based products. Take note that in certain tests, we use iodine-based media in order to check our patients. So we have to rule out any allergies of our patients. Family history, of course, in this case, we have to question about the presence. We have to take note of questions about the presence of neurologic disease or other diseases in the immediate family, which may elicit valuable information about risk factors such as those for stroke or other neuromuscular diseases. An example of which, before that, what do you mean by immediate family? That means your direct ascendants and descendants. Ibig sabihin, your father or your children. We also have here your review of systems under your health history. So for your review of systems, you have to take note of any signs or symptoms that would indicate any problems with the neurologic function, such as fatigue, weakness, headache, dizziness, vertigo, changes in vision or hearing, and the like. We also have under your functional assessment, we have to document whether present symptoms interfere with the patient's usual activities and occupation. So under your functional assessment, we have to look into the sources of stress of our patient, their usual coping strategies. What else? And the source of support from our patients. So for example, who would usually support the patient financially, or does the patient have any family member with him? Others would be taking note of usual occupation and activities of the patient, effect on life, changes in sexuality, changes in the activities of daily living. Ibig sabihin, you'll have to take note of any changes in the usual activities of the patient after the patient started experiencing signs and symptoms. Sources of stress, again, which was mentioned a while ago, coping strategies, and sources of support. After your health history, we also have here your physical assessment. In your physical assessment, there are actually 4 major components of your routine neurologic examination. Please take note that the complete physical examination, including the neurologic examination, should be done when the patient is stable. So when the patient is already, you know that the patient is at high risk or critical ang ating patients, that's the time we do not have to do complete or we do not have to follow the step-by-step procedure on physical examination and neurologic examination. We will only focus on those that are very important. Dapat mabilisan lang because again, very critical ang ating patient. A neurologic assessment provides baseline data to compare with ongoing assessments and serves as the basis for developing the nursing care plan. So, for example, one elevated blood pressure reading may not be significant, but continuing increases of the blood pressure may be associated with increased intracranial pressure. So, for example, you noted that the patient's blood pressure is 130/90. After some time, after 30 minutes or an hour, you check that the patient has had an increase in the blood pressure to 150/80. And taking note of the pulse pressure, medyo widened na siya. So this would now possibly indicate an increased intracranial pressure. So what are the four major components of your physical assessment? We have level of consciousness, pupillary evaluation, neuromuscular response, and the vital signs of our patient. So let's discuss them one by one. The first one is your level of consciousness, or your LOC. So this is the most accurate and reliable indicator of your neurologic status. So how do we evaluate the level of consciousness of our patients? That's by taking note or evaluating the patients for orientation to person, place, and time. So how do we do this? By asking them to state their name, where they are, and what time it is. So you'll have to ask them, Mama niya tinagan nyo, ay nati ayan nyo tadta. Kan anya ba ti oras tadta? So those are questions you can ask your patients. So any alterations in the level of consciousness would usually indicate either somnolence, lethargy, stupor, semi-coma, and even coma. So what are these different level of consciousness that would indicate abnormalities? So first, we have here your somnolence. In your somnolence, there is an unnatural drowsiness or sleepiness. Lethargy, on the other hand, is excessive drowsiness. Please take note that sometimes they would interchange, or they would put together somnolence and lethargy as having the same meaning. We also have for your stupor, if there is decreased responsiveness accompanied by lack of spontaneous motor activity. For your semi-coma naman, if the patient is stuporous but can be aroused, usually they can be aroused by painful stimuli only. And the last one is, of course, the worst level of consciousness would be your coma, where the patient cannot be aroused even by powerful stimuli. So when we're trying to stimulate the patient, we usually follow a certain order by first using verbal stimuli. So with verbal stimuli, you try to talk to the patient. You tell them their names. If hindi pa nag-respond ang pasyente, that's the time we use tactile stimuli. First, by shaking the shoulder gently. And then, if hindi pa rin nagising ang ating patient, or if our patient did not respond after shaking the shoulder gently, that's the time we actually use our painful stimuli. In your painful stimuli, what are the appropriate methods? So we have here applying pressure on the nail bed using an object such as a pen, or pinching the trapezius muscle firmly between the thumb and forefinger and twisting. So how do we stimulate the patient? First is through verbal stimuli. So ask or tell the patient, or gisingin natin yung pasyente using verbal stimuli by talking to the patient. Pag hindi pa magising ang pasyente, that's the time we use tactile stimuli by holding the shoulder of the patient and then shaking it gently. If the patient awakens or if the patient responds, then okay na. Pero pag hindi pa rin, that's the time we actually use painful stimuli. What are these? How do we do this? By, of course, taking note of the nail bed of our patients. Usually, you get a pen and then you press over the nail bed of our patients. You can also use your finger to press on the nail bed of your patient. Another way is also using your thumb and your forefinger. You're going to clamp it over the trapezius muscle sa ating shoulder ng pasyente. You pinch it and then you're going to twist it a little bit. So that would already, hopefully that would already stimulate the patient, and the patient would eventually elicit a response. If, however, the patient does not elicit a response, what happens already in this case? That would indicate possible coma. Yan. Pag sa semi-coma, for example, kailangan ng painful stimuli, saka lang siya nagre-respond. And sometimes they would only respond to or they will just wake up and then they will sleep again. Next would be your pupillary evaluation, which is another part of your physical assessment. In your pupillary evaluation, what do we do here? We evaluate the pupils, assess and compare their size, shape, and reactivity. The average size of the pupils would be 3 millimeter in size. The normal size or the normal diameter would be 2 to 4 millimeters. So, ang average natin is 3 millimeters. So, that is when wala pang light na nakadirect sa ating mata. That is when there is light. That is when there is light. That is 2 to 4 millimeters. If, however, again, in this case, nagkakaroon ng dark, pag dark yung environment, it would go up to 8 millimeters. Beyond that is already abnormal. What else? How do we assess a normal, or how do we usually know if the pupils are normal? Again, by shining light over the eyes. If you shine light using your pen light over the eyes of a patient, dapat nagko-constrict yung pupils. And if you're going to look at the other pupil that has not been shown a light, dapat pati rin siya nagko-constrict. You also have to take note of the shape of the pupils. Dapat round. Both pupils in both eyes should be round. What else? The closer the object the patient sees, mas nagdadilate dapat ang ating mata, ang ating pupils. Okay, so in this case, we also have here the term perla. Your perla is actually used to indicate a normal pupillary evaluation. So perla means pupils are equally round and reactive to light and accommodation. Yan. Changes in equality or reactivity from one assessment to the next may indicate neurologic deterioration. Next, let's go to the other category of your physical assessment, which would be your neuromuscular response. Under your neuromuscular response, so in this case, assessment of neuromuscular response provides a means of evaluating cerebral and spinal cord function. So in this case, voluntary movements and reflexes are being assessed. So for your reflexes and movements of the body, so we have here in your table, in this table, we have here the different nerve roots. So it has something to do with your spinal cord. What are usually, or what do these nerve roots usually do? So in this case, for example, the C4 to your C5 is responsible in abducting the shoulder. C5 to C6, they are responsible in flexion of the elbow, which would now cover your biceps. How do we assess our nerve roots? First, of course, in your C4 to C5 para makita natin kung meron or walang problema sa ating C4 and C5. We have here, let the patient shrug shoulder against downward pressure. If the patient is able to shrug his shoulder, pag tinaas niya yung shoulder niya despite putting pressure on the shoulder, ibig sabihin yung C4 to C5 ng pasyente natin is properly functioning. So that is for your neuromuscular response. Next, let's go to our motor system. In your motor system, we are going to look into the muscle of the patient. So in this case, we look into the size and symmetry of the muscles. So how do we do this? Through palpation. We do this through palpation, and we try to look into possibilities of the presence of atrophy or involuntary movements. So for your atrophy, this is what it would look like. Ayan. So that is muscle atrophy. So in this case, this is your normal muscle. If active yung muscle natin, usually they would increase in size. While for inactive muscles, an example of which is in the case of your stroke. So muscles are inactive and eventually they they undergo muscle wasting, kaya nagkakaroon ng atrophy. Another abnormality in the size and symmetry of our motor system or in the muscles would be your involuntary movements. So the picture you see here or the GIF you see here is actually an example of your tardive dyskinesia and your pseudo-Parkinsonism. Your tardive dyskinesia and your pseudo-Parkinsonism. So these two are actually symptoms of your side effects of your antipsychotic medications, specifically on your medications that would cause extrapyramidal symptoms. So hopefully in your psych subject, you're able to discuss the side effects of antipsychotic medications for schizophrenia usually. These medications, these traditional or conventional medications, would usually have what you call your extrapyramidal effects. These extrapyramidal effects, kung nagkakaroon ng overdose or masyadong madami yung gamot na naibigay sa pasyente, again, this can cause these extrapyramidal symptoms known as your tardive dyskinesia, kung saan nagkakaroon ng, protruding of the tongue, drooping of the face. For your pseudo-Parkinsonism naman, that would be your pill rolling. Parang may hawak siyang pill, tapos niro-roll niya yung pill. So these are actually side effects of your conventional antipsychotic medications. Extrapyramidal symptoms. Ayan. So these are actually involuntary movements. What do you mean by involuntary movements? Meaning, hindi makontrol yan ng pasyente. So they automatically appear in our patients. So we also have here your tone. For your tone naman, we look into the tension present in a muscle at rest. So palpating various muscle groups at rest and during passive movement, we try to look into possibility of abnormalities known as your spasticity, rigidity, and your flaccidity. Your flaccidity would usually refer to your muscle weakness. So again, atrophied muscles would usually be flaccid. What else? In terms of your spasticity and your rigidity, in this case, for your spasticity, this is common in stroke. So this is common in stroke where there is actually weakness. So usually, when you try to do a passive exercise on the patient, wait, let me just show you. Yeah. So for example, we're going to do a passive exercise for our patient. For passive exercises, you're the one who will be moving the muscle of the patient. So there are times when you try to extend when there is spasticity in the patient after a stroke, for example, there is spasticity if when we try to flex, for example, the muscle, medyo iba yung resistance. Pero pag when you try to flex the muscle of the patient, hindi siya ma-flex. I think that is common. I'm not sure if you're able to encounter this once. So an abnormality in the tone would be your spasticity. In your rigidity naman, this is usually common in our patients with Parkinson's disease. So in your Parkinson's, regardless of what movement you do with the patient, rigid pa rin yung muscle ng pasyente. Ibig sabihin, nagkakaroon ng resistance. When you try to flex the elbow of the patient, hindi siya ma-flex. When you try to extend the elbow of the patient, again, hindi rin ma-extend. That's the difference with your spasticity, because in your spasticity, there is muscle weakness. In your rigidity, there is no muscle weakness. And then the resistance is always the same in any type of movement. Sa spasticity naman, there would be variations in the resistance when you try to do other passive movements. Next, let's go to your motor system. In your motor system, we try to rate the muscle strength of our patients. For your muscle strength, we try to rate the strength of our patients. Usually, when we try to rate the strength, we focus on the limbs of our patients. So the point system of our muscle strength would be from 0 to 5. 5 indicating full power of contraction against gravity and resistance. 4, if the patient is able to resist your pressure pero merong slight weakness. For number 3, in this case, the patient walang resistance na binibigay ang nurse or ang doktor. Ang nangyayari lang in this case, the patient is naturally able to overcome the force of gravity. And for your 2, again, the patient is able to move his limbs. However, he cannot move against the gravity. For number 1 naman, there is contraction of the muscles, but the patient cannot move his limbs. 0 again indicates complete paralysis. Again, I'll show you an example for your nakita nyo ba? A score of 5 would be when you're going to apply pressure over the hand of the patient. For example, naka-flat yan, no? Meron kang ina-exert na pressure over the hand of the patient is able to fully resist your pressure. So in this case, ayan, ganyan. Next would be number 4. For your number 4, again, the same pressure is applied on the hand, and then you ask the patient to lift his arm, for example. If the patient is able to lift his arm against the pressure that you exerted, pero may slight weakness, meaning di nila fully kayang i-resist yung pressure na binibigay mo sa kanila, then that would be a score of 4. For a score of 3 naman, again, in this case, we do not apply pressure. So yung nurse, hahayaan lang niya yung kamay ng pasyente, and then the patient is able to pull his hand up. Kaya niyang itaas ang kanyang kamay. Diba? Take note, merong force and gravity pababa. But the patient is able to resist that. For number 2 naman na, sa number 2 naman na score, in this case, kaya niyang ma-move side to side. But the patient is unable to go against the pressure of gravity. So in this case, hindi niya kayang itaas. Pero kaya niyang i-move side to side. So that is number 2. If number 1 naman, you look at the arm of the patient, nagko-contract naman yung kamay niya, but he is unable to do movements, hindi niya kayang maigalaw any movement, hindi niya kaya, then that would be 1. Complete paralysis, on the other hand, would be a score of 0. Next. Motor system. Usually, if you look at this one, in the assessment charts, usually ganyan yung drawing. So, 5 out of 5. So, ibig sabihin yung muscle strength niya on his left upper limb is 5 out of 5. Right upper limb is 5 out of 5. Left lower limb, 5 out of 5. Right lower limb pala. And then left lower limb. So, take note in this case, yung iba, meron actually assessment pa on the upper limbs here and then here. So, you would usually test the distal and the proximal limbs. So, minsan, dalawa yung score sa isang paa. Dalawa ang score sa isang paa. Because the other one would cover the thigh up to the knees, while the other one would cover the knee up to the foot. Ayan. What else? We also have to take note that under your motor system, we also check balance and coordination of the patient through our Romberg test. I think that will be discussed later on. So for your Romberg test, it is a test that is used to measure balance or to assess balance and coordination of the patient. So you ask the patient to stand with his feet together and arms at the side. Una, the eyes would be open, and then after that, ask the patient to close his eyes for around 20 to 30 seconds. Normally, the patient should not fall. Slight swaying of the patient is normal, but a loss in the balance of the patient is already an abnormal finding. That is under your Romberg test. We also have here your reflexes. In your reflexes, we have your deep tendon reflex responses are often graded on a scale of 0 to 4 positive. So 4 plus. So a score of 4 plus indicates a hyperactive reflex, meaning that is still an abnormal finding because it can indicate pathology. This is a condition known as your hyperreflexia. 3 positive naman indicates a response that is more brisk than average but may be normal or indicative of disease. So again, this may be normal. This can also be associated with an abnormality. The normal response is actually 2 positive. 1 plus naman indicates a hypoactive or diminished response, and 0 indicates no response at all. So an example of which is your biceps reflex. So in this case, we strike the bicep tendon of the flexed elbow, and normally dapat nagkakaroon ng movement of the arm. I will show you examples. So this is an example of your bicep and your tricep reflex, your knee jerk reflex. We also have here your Babinski, and then we also have here one that is one where the hammer is struck on the Achilles area or the ankle. So we have the first one. I'll show you a video.
In this video, we are going to look at reflex testing of the upper extremity. Hi and welcome back to Physio Tuners. Reflex assessment is an essential part of neurological examination when suspecting radiculopathy, as abnormal deep tendon reflexes may help you in identifying the pathological disc level. In case of the cervical spine, the most common causes of nerve root pathology are herniated discs, which account for about 20 to 25% of cases, and degenerative disc disease, which accounts for 70 to 75%. While herniated discs, also known as soft disc lesions, are rather seen in younger patients, degenerative disc disease or hard disc lesions primarily occur in the older population, and the highest incidence for cervical nerve root pathology is found on spinal segments C5-6 and C6-7. In their systematic review from 2017, Lemonnier et al. Report that a complete peripheral neurological examination when suspecting cervical radiculopathy has a sensitivity of 83% and a specificity of 28.15. Upper extremity is always considered 4+ equals a clonus, which is always abnormal. Now, if you want to learn about a pathological...
Okay, so that is for your biceps and triceps. For the lower limbs, on the other hand, we have here an example.
This is going to be a video on reflex assessment of the lower extremity. Hi and welcome back to Physio Tuners. Reflex assessment is an essential part of neurological examination when suspecting radiculopathy, as abnormal deep tendon reflexes may help you in identifying the pathological disc level. Al-Nazari et al. From 2013 performed a systematic which is always equal. If you want to learn about a pathological lower limb reflex.
Okay, so those are the different ways on how we assess reflexes of our patients. Now let's move on to the next one. Okay, we have here reflexes. So this table would usually indicate how you score reflexes. So deep tendon reflexes are graded on a scale of 0 to 4. 0 for no response, diminished. Pag hypoactive ang ating reflex, normal would be 2. Increased may be interpreted as normal, but sometimes it can also indicate disease. Hyperactive if there is hyperreflexia. So the deep tendon responses and plantar reflexes are commonly recorded on stick figures. So you would usually indicate here these scores. So for your response here, I forgot the term for that. Usually a normal indication of a normal finding in a reflex located here would be a downward arrow. Kasi pag pataas yan, that would be abnormal. So we have here what are the expected or the normal responses for each reflex. For the biceps, there should be flexion of the forearm. For triceps, there should be extension of the forearm. For your brachioradialis, that would be flexion and supination of your forearm. Quadriceps, that would be extension of lower leg. Achilles would be plantar flexion of the foot, and clonus would be repetitive movement after brisk dorsiflexion of the foot. Now let's go to the last one, would be your vital signs, which is part of your physical assessment. For your vital signs, very important to monitor pulse, respirations, and blood pressure, which would provide highly reliable information regarding the neurologic well-being of our patients. Take note that any changes in vital signs are late indicators of deterioration. So take note that hindi palaging ang basis natin would be the vital signs. Take note that in certain instances, the vital signs would also indicate other morbidities or other problems in the patient. However, this could, or any changes in the vital signs may still indicate possibilities of neurologic disorders. An example of which, as mentioned a while ago, usually if there is hypertension and an increase in the pulse pressure of the patient would already indicate an increased intracranial pressure. Okay, we will continue with the diagnostic test and procedures for the next video lecture. So this is a total of 30 minutes. If you have questions, you can just ask me through Google Classroom or through Messenger in our group chat, and also through the YouTube channel. You can also ask questions there. Thank you.